So we are going to talk about benign positional paroxysmal vertigo. Benign positional paroxysmal vertigo is a vestibular disorder. To say more specifically, it's a peripheral vestibular disorder. So vestibular disorder is some kind of disorders in which vestibular organs have difficulty in receiving, transmitting the informations getting through it due to the damage to vestibular end organs or vestibular nerve or brainstem or the central connections. So there are two types of vestibular disorders: peripheral vestibular disorder and central vestibular disorders. Peripheral vestibular disorders is the lesions of vestibular end organs and vestibular nerve. Examples of it are maniastasis, BPPV, vestibular neuronitis, acoustic neuroma. Then central vestibular disorder is due to the lesions of brainstem and central connections. Examples of it are multiple sclerosis, vertebrobasilar insufficiency, posterior inferior cerebellar artery syndrome, and basilar migraine. Moving on to the definition of the benign positional paroxysmal vertigo. It's a peripheral vestibular disorder. It's characterized by the vertigo when the head is placed in certain critical position, such as picking an object from the overhead shelf. So what do you mean by vertigo? If we feel like the dizziness and all our surroundings start to rotate, that's called as a vertigo. And that phenomenon happens when we place our head in a very critical certain positions, and that's characteristic of BPPV, and that's the definition of the BPPV. It's a peripheral vestibular disorder characterized by vertigo when the head is placed in certain critical position, such as picking an object from the shelf overhead. Then pathophysiology of BPPV. So talking about the pathophysiology of BPPV, we need to talk about the whole of the cochlea. The cochlea is a bony labyrinth, a bony structure, and it consists of perilymph. The whole of the cochlea consists of perilymph, and the orange color thing right here, that thing. This is the membranous labyrinth, or it's also called as membranous. It is membranous labyrinth, and it consists of endolymph. So it is also called as endolymph organ, and this endolymph organ is the orange colored thing in the one I marked here, and the orange colored thing, that is the endolymph organ, consists of utricle, saccule, and semicircular canals. You know what is a semicircular canal, right? These round things are the semicircular canal, and so the semicircular canal. Then we're gonna talk about macula. The utricle and saccule, both of them contain macula. This blue colored thing you see right here is the macula, and its enlarged view is seen in here. Look at this. And this is the autoconia. Autoconia means a calcium carbonate crystals are arranged here as a rectangular shaped debris in the macula, and as we ages, this autoconia degenerates and it becomes depressed and displaces to the endolymph inside the membranous labyrinth, and which falls on here, right here. This is the ambula of semicircular canal, that's the bulged out part of the semicircular canal, and in here there's a blue color thing, right? You see a blue color thing. It's enlarged view is seen here. This is the cupula, this thing, and these are the hair bundles right here. These are the hair bundles. These things are the hair bundles, and these are the nerve fibers, hair cells. So the cupula, hair bundles, nerve fiber, hair cells, and this all together is called as cristae. And when the otoconal debris displaces to the endolymph, and it may get deposited on the crista, especially on the cupula, it can stimulate the hair bundles and cause impulses to be released, and it will get us a feeling of vertigo, and that's the whole thing behind the benign positional paroxysmal vertigo. And so let's talk about the pathophysiology one more time. The otoconal debris, which consists of calcium carbonate crystals, is released from degenerating macula of the utricle. So where will you see the macula? In both utricle and saccule, but the otoconal debris in the macula of the utricle turns into the otoconal debris and displaces to the cupula, and it flows freely in the endolymph. Okay, it floats freely in the endolymph, and when it settles on cupula of the semicircular canal, okay, in a critical head position, when we place our head in a critical position, it gets deposited in the cupula of the crista of the ambula of the semicircular canal. It causes mainly the posterior semicircular canal, and it causes the displacement of the cupula and causes vertigo. It causes the displacement in the cupula, and the hair cell stimulates and causes vertigo. Vertigo will subside if we keep the head in same position. Okay, if we keep the head in same position for a long time, the otoconia will disperse itself, and the vertigo will subside itself, but it will again get induced after a period of rest. When we suddenly moves our head and the head gets into a critical position, it gets induced again, we feel vertigo. Okay, so that's all about the pathophysiology. Then this is the all of the big, and we move on to diagnosis. What about diagnosis? So we diagnose the patient based on the patient's typical history and Hallpike maneuver. It's actually called as Dix-Hallpike maneuver. Okay, so when we talk about the Dix-Hallpike maneuver, let's go to more slide in front. So this is the Dix-Hallpike maneuver. We will read the sentence here. With the head turned 45 degrees, the patient made to lie down in the head hanging position. So just before that, management of BPV. By performing Epley's maneuver, we perform Epley's maneuver to manage the case of benign positional paroxysmal vertigo, and the principle behind Epley's maneuver is repositioning the otoconal debris from semicircular canal back into the utricle. Okay, in this In the case of BPPV, the autocorneal debris get displaced from the macula of the utricle to the cresta of the semicircular canal, and it is all about repositioning to its original place. It's the principle behind Epley's maneuver, and doctors should stand behind the patient and assistant should stand aside of the patient, and the patient is made to sit on the table so that when he lies down the head is beyond the edge of the table. Okay, when he lies down the head will fall beyond the edge of the table and his face is turned 45 degree to the affected side while he is lying down. Okay, then in the diagnosis we talked about the Hallpick maneuver, and we are going to talk about Hallpick maneuver now. So with the head turned to 45 degree, we already talked about it. The patient is made to lie down in the head hanging position, and this is the Dix-Hallpick maneuver. Okay, this is the Dix-Hallpick's maneuver used to diagnose BPPV in the patient. How will we diagnose BPPV using the Dix-Hallpick maneuver? Because the patient will develop nystagmus and the patient will experience vertigo when we do Dix-Hallpick's maneuver to the patient. That is, with head turned 45 degree, the patient is made to lie down down in the head hanging position. Patient will develop nystagmus and vertigo. And so it's a posterior sign for BPPV. And about the Epley's maneuver, the Dix-Hallpick maneuver is itself the first step for the Epley's maneuver, and we should wait till the nystagmus and vertigo subsides, then go on to the next step of the Epley's maneuver. That is, the head is turned so that the affected ear is facing up to head is turned so that the affected ear is facing up at a 90 degree rotation. That is, the patient's affected ear should be facing to the doctor on the upward side. Okay, then third step is whole body and head are now rotated away from the affected ear to a lateral recumbent position in a 90 degree face down position. Okay, so we first take the patient to lie down in the lateral position with a 45 degree head turned to the affected side. Then we push the head to 90 degree and make sure the affected ear is upwards, and then we turn the whole body and head now rotated to again a 90 degree position so that the affected ear is in the rotated away from the affected ear to a lateral recumbent position. So the affected ear will gain a lateral recumbent position in a 90 degree face down position, and the patient is now brought up to sitting position with the head is turned to the. So the next step is the patient is now brought up to sitting position with head still turned to the unaffected side by 45 degree. Okay, and the head is now turned forward and the chin is brought down by 20 degree. That's all.